هو ممكن تختاري اسمه وتخليه
تمام. change the host.
وانا اسمي اللي هو بحرف الاي ده، ايوه ده.
change host. yes.
تمام.
ما فين كده كده
كنت
نفعت
ممكن
كده؟
اعمل انا كده. نعم.
نفعت كده؟
ان شاء الله. هو كده اداني قال لي شير وايت بورد ولا اعمل شير سكرين؟ شير سكرين مش كده؟
شير سكرين ان شاء الله. recording stop.
المايك يا دكتور علاء.
كده يا جماعه الشاشه شيرد ولا لا؟ معلش لو جماعه لو حد بس الشاشه كده شايفينها.
لا لسه انا بالنسبه لي لسه يا دكتور احمد.
لسه يا دكتور احمد.
غريبه جدا.
يلا بس احمد عندي. يلا يلا مش حاجه، تلاقي حاجه بسيطه يعني.
طب انا هضطر اخرج وادخل تاني، معلش ادوني دقيقه واحده تاني.
يا دكتور علاء المايك يا دكتور علاء.
دكاتره السلام عليكم. احنا لسه ما بدأناش. دكتور احمد خرج وده هيدخل تاني ان شاء الله عشان بيظبط الزوم بتاعه. ما تقلقوش ان شاء الله خير.
يا دكتور علاء المايك، والله زهقنا من صوت الاسعاف. ازيك يا دكتوره رمزيه؟ كل عام وانت بخير.
السلام عليكم. ازيك يا دكتور؟ عامل ايه؟ كل سنه وانت طيب، رمضان كريم. كل سنه وانتم طيبين جميعا، رمضان كريم. عاملين ايه؟
كل سنه وانتم طيبين جميعا. طيبين
الحمد لله تمام. الله اكبر. بكره 10:30 يا جماعه، مش 9 عشان ما حدش يجي بدري.
طب كويس ان انت قلت يا عبد الستار عشان انا
يا عم حد يتصل على علاء، والله انا اتوترت. انا لسه راجع من الشغل يا رب، ده هو يوم اجازه واحد اسمع هنا صوت الاسعاف في البيت كمان.
قفل لك المايك اهو يعني.
السلام عليكم ورحمة الله.
وعليكم السلام ورحمة الله
وعليكم
وبركاته.
السلام
عليكم
ورحمة الله
السلام ورحمة الله
وبركاته.
وبركاته. الحمد لله على السلامة يا دكتور أحمد.
الله يسلمك.
عليك
كده
كده
في
هوست.
شيء كده ايه؟
حضرتك كده
الاتنين-
هوست تقدر تعمل شير سكرين.
ما انا عملتها ما فيش فايدة برضو، مش فاهم ليه. طيب ثانية واحدة اعملها تاني. كده تمام؟
تمام كده يا دكتور أحمد.
يا
كده
رب كده
تمام.
تشتغل. طيب تمام. بسم الله الرحمن الرحيم. انا اسف جدا على التأخير العظيم ده، بس معلش احنا اسفين جدا.
ده
كل سنة وانتم
الحمد
طيبين.
لله على السلامة. لسه راجع من السعودية. الحمد لله على السلامة. منورنا.
طيب هقول لك على حاجه مهمه، يعني ان شاء الله كل سنه وانتم طيبين، رمضان كريم. وانا متشكر ليك يا دكتوره منى بجد، ان يعني انا الحقيقه كنت قلقان ان انا اعرف اعمل ده لاني ما كنتش عارف مواعيدي، بس يعني كتر خيرك انت اللي كنت واقفه جنبينا وعملت لنا سبورت عظيم جدا. انا الحقيقه بشكر جمعيه القلب كلها الحقيقه اللي واقفين ورا الموضوع ده. بشكر حضرتك لان انت الحقيقه ما شاء الله سوبر باور في الاجنيشن اوف ذيس ميتينجز. الحمد لله. بشكر كل الاستاف او كل الاخوه البارتيسيبانتس، ويا رب اكون على قد حسن ظنكم، يعني ان انتوا لو عندكم، لو اقدر انا عندي معلومه اقدر اشير المعلومه دي معاكم. بسم الله الرحمن الرحيم. عايزين نبتدي ان شاء الله. احنا بنتكلم النهارده عن المايوكارديال بيرفيوجن ايميجينج. هو الحقيقه المايوكارديال بيرفيوجن ايميجينج هو عباره عن non invasive detection of myocardial ischemia, and it is measuring the degree of coronary flow limitation both in rest and in exercise. وبالتالي فهو جزء منه مهم قوي يبقى physiological measurement. So that means that it reflects the functional consequences of the coronary flow limitations. The heart is considered, point this is مهم قوي، ان the heart is considered the most active metabolic organ or metabolic muscle inside the muscular bed of the body, and the oxygen extraction usually in the heart even in the resting condition is the highest. يعني فاحنا يعني دائما الاكستراكشن of the myocardium to the oxygen is يعني immediately is the maybe on the tip of the top of the other organs. وبالتالي increase of the myocardial oxygen demand على طول بيحتاج immediately it needs increase in the myocardial blood flow. It cannot be, there is no shift to the left to increase the extraction from the hemoglobin. Only increasing the blood flow is the one, it will ensure the increase in the myocardial blood flow. طبعا الكلام ده انتوا كلكم عارفينه اكتر مني. طيب what is the definition of the myocardial perfusion imaging؟ هو عباره عن intravenous administration of radioactive substances these substances are extracted immediately by the myocardium, and it has a good stability inside the myocardial muscle, and it emits gamma rays or beta rays or X-ray, whatever, to be captured by an external source, external camera. يبقى هو intravenous administration of a radioactive substance extracted by the myocardium in accordance or in relation to the myocardial or regional myocardial blood flow and according to viability. And then there is a construction of a 3D images and color coding that is obtained according to the differences in the regional myocardial blood flow and or viability. What is the principle of indications? Indications بتاعتهم الحقيقة خلينا نتكلم صراحة ان الانديكيشن of the myocardial scintigraphy ابتدى يقل شوية، لكن still it is very widespread, readily available, and it has a reproducible data. يعني هو very good sensitivity and very high يعني very also يعني reasonable specificity for detection of myocardial ischemia and detection also in myocardial viability. However, the diagnostic purposes يعني still it is very important in the diagnostic as a diagnostic tool for the detection of myocardial ischemia source or chest pain source. خلينا نتكلم يعني هي very important. هو very cheap tool, very readily available, موجود في everywhere يعني فبالتالي still حتى الآن until now we can use it very easily and we can exclude ischemic heart disease from the chest pain, or we can prove the ischemic heart disease if the patient has a chest pain, and also we can detect myocardial viability. يبقى احنا عندنا diagnostic purposes for the patients who has recurrent chest pain and suspected angina pectoris or ischemic cardiac disease. It also works for the diagnostic purposes of acute chest pain with non-diagnostic, other non-invasive methods. يعني sometimes it was used sometimes from the ER. We can give one single shot injection and then immediately go for taking picture for a patient to exclude if there is an ischemia or no ischemia. Sometimes it was that, but it can be accomplished sometimes in some hospitals. It also the preferred physiological non-invasive tool for patients with initial ECG changes obscuring diagnosis, like the left bundle branch block. يعني sometimes if you want to make an exercise test for a patient to make a diagnosis and the patient has left bundle branch block, has LVH like that, يعني usually the data will be obscure. يعني these ECG preliminary ECG changes or resting ECG changes will preclude the data. So better to go for a non-invasive physiological tool like this one. Also, it is very good in the assessment of prognosis and risk stratification of the patients. طبعا although now we have another يعني مع introduction of the CT, مع introduction of the calcium scoring through the CT, مع introduction of the MRI, الدنيا ابتدت تتغير. انما it was very important in the prognosis and risk factor, risk stratification for the patients, and it is also a very cheap tool. يعني نقدر نقول ان هو cheap tool and it is reasonable tool for assessment of myocardial viability. طبعا مش هنتكلم عن الام ار اي، لكن دلوقتي احنا بنتكلم عن assessment of myocardial viability. It's a very still until now it is dependable data. Data بتاعته can be dependent that we can detect viability. We can expect the improvement of ejection fraction in hibernating patients, in hibernating myocardium, in stunned myocardium like this. Right. The principal components of the radionuclide imaging. If I want to have this image, what I should have, the components of the test, the patient is exposed to what? We should have a radio tracer. This radio tracer should have a good characters from مثلا being extracted by the myocardium, the living myocardium, and the ischemic myocardium also, and it is readily distributed all over the myocardium. It should have a special affinity to the heart, not to the other muscles or to the liver like that, as we can see. And also this tracer can emit photons or can emit an X-ray or gamma rays that it can be captured by special cameras. And this will lead us to go for the gamma camera. This gamma camera, which usually it was in very old, it was one head, and then it started to be dual head, and even recently there are some cameras with triple hit. طيب, and there is a multiple image protocols. يبقى الثلاثة components, these three components are very important: the radio tracer, the gamma camera itself, and the imaging protocol. طيب, for that radio tracers احنا عندنا اثنين اساسيين دلوقتي حتى الان: الثاليوم 201 وعندنا اللي بعديه التكنيشيوم 99، يا either التكنيشيوم سيستميبي او تتروفوسومي. السايكلوترون الثاليوم 201 هو بيطلع عن طريق 1 سايكلوترون، يعني هو بيتحضر في مكان في معمل لحظة واحدة. هو بيتحضر في يعني في مفاعل مكان معين او في its own generator او سايكلوترون خاص بيه، and it is transmitted immediately from that place to the place of the imaging, to the hospitals with that tool. الحتة ديت is a very important limitation, because once you have started to generate this radio tracer, its half-life starts to decay. The method, even the radio tracer usually starts to decay, and this decay, so that means that for the transmitting this material from the site of origin to the site of use, sometimes you can have some decays and you can lose part of the tracer. So it is a cyclotron production. But there is something very important, because it has a long life. A long half-life الحقيقة is good for the transport of the material, because this long half-life gives us good expectancy that we can transmit to the hospitals, and then it can be used by the patients. But it has also another drawback for that one, because we cannot inject higher doses for the patient, because the patient, if we give the patient very high dose of this thallium, then the patient will emit X-rays or gamma rays for a very long time. Maybe it takes مثلا 2 weeks or something like that, and this will be harmful for the patient and for the surrounding people or relatives in his house. The attenuation problems of this of the thallium is frequent attenuation problems. Why? Because it is a low emission. It has a low dose emission of gamma rays. It is just calculated from 69 up to 83 keV. تمام. The uptake is also dependent on the regional myocardial blood flow. This is very important. This is very good advantage. Why? Because once if you have a muscle area, part of the muscle of the myocardium, and this part of the muscle has a very good myocardial blood flow, then the initial injection of this material, it will immediately be extracted by this normal myocardium, because it has a normal myocardial blood flow. In contrary, if you have a very stenosed muscle, that means that a very stenosed coronary artery, that means that the area supplied by that coronary artery is very ischemic, or have an ischemia or suffer an ischemia, then the myocardial blood flow is very low, and hence the extraction of the myocardium for the tracer will be also very low. This is the principle of the detection, because when you see the image, the reconstructed image, you will find an area with normal myocardial blood flow having very good amount of the tracer emitting gamma rays, and another neighbor area with very low myocardial blood flow, and then it appears so dark. So dark means that it's black. It is not emitting, because there is no sufficient amount of the myocardium could extract the tracer. This is a very important point for the diagnosis. Right. The effective dose that it should be injected in the patient, usually if equivalent to 80 megabecquerel. This is usually we inject for the patient 80 megabecquerel when we are doing for him an stress, and if the patient is taking a re-injection dose, and we will understand also what is the stress and the re-injection, usually we can raise our dose up to 120 megabecquerels. Right. There is also a very important drawback in the thallium, which is the poor counting statistics. What is this one? Counting statistics, usually we can, the new cameras and the new digitized analysis of the data can make a statistical counting for each regional myocardial area, and this can perform it can make counting to calculate the amount of the tracer uptake inside the myocardium. Usually this phenomena or this calculation allows us to make a good calculation for the left ventricular function, the left ventricular dimensions, the end-systolic dimension, end-diastolic dimension, and calculation of ejection fraction. And because this thallium has a poor counting statistics, usually we cannot get these important functional data. So mainly from the thallium, we can get presence or absence of ischemia, we can get presence or absence of viability, but we cannot get a good data for the left ventricular function in most of the time. Right. But also this, and then the final point, it was that the patient has a low, or the thallium has a low subdiaphragmatic uptake. So it is favorable for early post-injection imaging. What does that mean? The subdiaphragmatic uptakes usually is the liver. The liver, sometimes we will find that one in the technetium has a very important affinity, have a very good affinity to the technetium. So once you are injecting the technetium, it goes to almost two places. One of them is the heart, one of them is the liver. And because of that, we will find that the patient, when comes for the stress, he is fasting, we give him the injection, and then advise the patient immediately to have a small fatty meal. This fatty meal will make an evacuation of the gallbladder and evacuation of the amount of the technetium already captured by the liver, so it will decrease the subdiaphragmatic attenuation. And then we can proceed for the imaging. This drawback is not present in the thallium. So immediately after the imaging, we can also take pictures for the patient like that. Right. What about the technetium-99 system-AB and the technetium tetraphosamine? Here we have the technetium. The technetium is the active substance, and the technetium is obtained from a source called molybdenum. This is the radioactive tracer, the immediate. What is the system-AB and the tetraphosamine? System-AB and tetraphosamine are biological carriers. These carriers are conjoined or junction. It makes junction with the technetium, and then it makes the technetium able to enter the body, able to circulate safely inside the circulation, and is able also to be uptaken by the myocardium. The difference between the two carriers is the system-AB and tetraphosamine, that we can combine the technetium with tetraphosamine in the normal body, in the normal room temperature. But for the system-AB, we have to make boiling, we have to make heating for the junction to be present, or for the conjunction to be activated. This is the only sign. And in most of the hospitals, you have a small laboratory that it has already very well equipped to have both, to use one of them. So it's very easy process actually. Right. For the technetium, the gamma ray emission is 140. This is written only 40. This is wrong. It's 140 keV. So that means it's very high, maybe almost double that emitted by the thallium. The short half-life is only 6 hours, in contrast to 72 hours. This is very important because it's very suitable to give large doses, and increasing the dose immediately will be reflected on increasing the emission of the gamma rays. Immediately will be reflected that we have an enhanced uptake, enhanced picture, enhanced counting of the pictures, enhancing images, enhancing the 3D reconstruction and the analysis. So it's very important. It's very, very much more better. It creates much more better images, better than the thallium. The production is from a kit and a generator. It means that when it is produced, this molybdenum material, when it is produced in its cyclotron, it can be transferred to any place around this cyclotron. So it can be in the hospital, and this molybdenum generator can stay in the hospital maybe up to 10 days, yani from almost 7 to 10 days. And through a process called the milking, then you can immediately extract the technetium and take this technetium immediately and put it in the patient. So now you have a very good source and a very readily, yani very good in the transportation. You don't have a loss of the material you are using, the radioactive tracer you are using, and also the technetium is freshly prepared, so it is not decayed, it is not and we have a very good quality of this radio tracer. So this is very important, that it has a very important advantage that it is already generated through a kit and a generator. The uptake is also dependent, like the thallium, on the regional myocardial blood flow. So it's very important also, and it can create a very good reproducible images that gives us a very good idea about the regional myocardial blood flow. The stable retention at the myocardium, this is very important. I think I did not mention it in the other one, because the thallium is acting once it is uptaken by the myocardium. Usually it acts like the potassium. You will find it in the next slides. Yani, because there is a process of redistribution. It is not stable for a long time. So it's very important to have a critical timing for taking the images. Otherwise, you will have a redistribution, and the technetium and the thallium will go out again from the myocardium into the circulation, because it tends to balance, just acting like the potassium. But for the technetium, it is not like that. For the technetium, usually it has a very good stability. Once it is inside the muscle of the myocardium, then it stays until it decays inside that one. It doesn't mean that we don't have some degree of redistribution, but it's very minimal, that it is negligible. So that it is a stable retention in the myocardium, so allow for delayed imaging. This is very important. But the problem is that it also, when each time you need to take an image, so you need to make an injection for the patient. So now you need to take 2 separate injections for the rest and the stress images. The standard dose can reach, you remember what was for the thallium? It's only like, this is for the thallium, it's standard dose from 80 to 120. But here we can reach up to 1000. We can up to 1000, because it's very short half-life. So that means that it will not be that harmful for the patient and for the relatives of the patient. And it has a very good counting in statistics. And that means that it allows us to have a gated SPECT images, single photon emission computed tomography images, and it has a very good reproducibility for calculating the left ventricular function from end-diastolic dimensions, systolic dimension, and calculating also the ejection fraction. But still, we have a very high subdiaphragmatic uptake, so that the imaging should be delayed from 30 to 45 minutes, maybe less than that one, up to 15 minutes. We can be less than this, according to the carrier, either systemib or totrifosine, and according to the patient, he is taking fatty meal or he did not take a good fatty meal. So these are the characteristics of the technetium-99. What is the difference between 2 of them? The chemistry, this one is, for the chemistry, it is a hydrophilic, the thallium. It's called thallous chloride, but it's also the thallium. And here it is a lipophilic. And because if it is lipophilic, it's very readily, it is very uptaken. It is taken immediately. If the gallbladder is full, then the liver uptake will be very high. Okay, the half-life is 73 hours. Here is only 6 hours. The uptake by the myocardium. For the thallium, it is highly dependent on the sodium-potassium ATPase pump present on the cell membrane. But for the technetium systemib, it depends on the presence of the mitochondria. So it usually depends on the passive diffusion through the cell membrane, and it is settled in the mitochondria. So if there is a well-integrated, well-living myocardial cell with a mitochondria, then it can be diffusely it can diffuse there and settle inside the mitochondria. If there is no, then there will be no uptake by the myocardial cell for the technetium. The extraction fraction, it means, what is the extraction fraction? When you are injecting any substance by units, 100 units of the substance, when you have injected this substance, how much of that substance entering the circulation immediately go and extracted by the myocardium? For the thallium, it is 85%. And for the system EB, it is 66%. This extraction means that it depends on each cardiac cycle, because each cardiac cycle around 5 seconds or 6 seconds. So that means that the heart uptake of the total myocardium from the total injected dose is only 4% in the thallium, and for the technetium it is less than that, it's only 1.2%. And for the redistribution, as we have mentioned, the thallium is redistributed because it acts as a potassium. Acting as a potassium, it tends to be redistributed in the circulation, and it tends to have a balance in the concentration between the myocardium and the extra myocardial sites. But for the technetium, it is fixed almost up to 6 hours because of the half-life. Here are the protocols for the thallium. The protocols, what are the protocols we are using? Actually, this slide is a little bit old, but it's very important. But we don't have too much changes for these protocols. In most of the time, for the thallium, we have a rest and a stress and redistribution, and plus minus re-injection. See, at panel A, usually the patient is making stress like pharmacological stress, treadmill stress, bicycle stress, whatever the type of the stress. Okay, so we are doing stress of the patient at the peak of stress. What is meant by the peak here? The peak here, we need to ensure that the myocardial oxygen or the myocardial blood flow is at the maximum. We usually reach the maximum starting to reach that one at 85% of the target heart rate predicted for the patient. So once the patient reaches 85% of his predicted heart rate, then you can inject your thallium and then take the stress images. Better to be SPECT image. After that, you should wait for 4 hours, around 4 hours, from 3 to 4 hours. This 4 hours will allow for another redistribution. The redistribution, it means that the myocardium which already make a very good uptake for the thallium, then the thallium will tend to balance again to the circulation and redistribute in other places of the body. Then you can take a redistribution image. If we need to detect viability, usually we go after that for what is called a re-injection dose. We can take a booster injection dose, and then we can make a re-injection image to see if we increase the dose inside the body of the patient, will the myocardium reuptake again the new dose and have an improved image again? Because what we will have here, if the myocardium is normal, the stress image, it will display a very good uptake for the myocardium. But after the redistribution, this uptake will decrease. So now you will have a stress image that it is very bright image, very good image, because there is a very good uptake. And then at the redistribution, you will have a even decrease of the amount of the thallium inside the myocardium. And if this myocardium is also still normal, you want to make sure that it is normal, and you give a re-injection dose to increase the total dose inside the body, then it will again make an uptake, and you will find an enhanced imaging inside, enhanced image once again. So this usually the sequence of the images. But we have also another protocol. We can start by the stress and take the stress image. This is B. You'll see here on the left panel, stress, and give the image and make the stress image and wait for 4 hours. Immediately give the re-injection dose and take the dose, take the image, and then wait for another 24 hours and make a very late delayed redistribution image after on the second day. Also, this pathway also, it is another enhancement. This actually is a very important for the detection of viable myocardium. Why? Because if it is this myocardium, if there is a viable myocardium and it's very severely ischemic, then the uptake in the stress and in the re-injection and redistribution, it will be very minimal. And in contrast to the other areas of the myocardium that already is taking very good amount of the myocardium, it usually appears as a dark point. So it's a black image. There is no uptake here. So I will assume in the first two images, this myocardium is non-viable. Alas, it's a dead myocardium. But if I waited for 24 hours, and we know already that we have a very long half-life, the redistribution will give time, allow time for 24 hours to this severely ischemic myocardial segment to make again an uptake. And once that happens, and there is a new balance between the normal myocardial uptake and the defective or the ischemic myocardial uptake, then you will have an enhanced image of the previously ischemic point or dark point. There will be like you will appreciate some uptake. This uptake will make you know that this myocardium is severely ischemic, but it is viable myocardium. So now you should make an intervention for this patient, whatever the type of intervention you want to go for. The third type of this one of the protocols is that you are giving a rest redistribution injection, only rest. There is no exercise at all. You will give a rest image, take the rest image, wait for 4 hours, make a redistribution image, and make another redistribution image after 24 hours. It's almost the same as B, but with exclusion of the stress if the patient cannot stress. So now we have many options for these injections. However, we need to know that in the thallium, it's very important that we have 2 images with one shot, with one dose, the stress and the redistribution, the rest and the redistribution. This is very important for detection of the myocardial ischemia, and it's very good in detection of the myocardial viability. What about the technetium? For the technetium doses, we have some different protocols, because here we should have, for each image, we should give the patient also another dose. For the technetium, we are doing the stress for the patient. We give him a stress. Look at panel A. At panel A, you make a stress for the patient. He reaches his peak exercise. You give him the technetium. You should wait for 15 minutes and order the patient to take a fatty meal, then go for the stress image. And then you can wait for 24 hours, or in B, you wait for 4 hours, 3 hours, 2 hours, like that. And then after 24 hours, give the patient another dose of technetium, wait for 1 hour, and then after the patient will have a fatty meal, and then you make a rest image. This is very important. Right. For panel B, it is not like that. You can give the dose immediately and wait for an hour, take the rest image, wait for 4 hours, and then we can make a stress image. So we can here start by the rest and then ending by the stress after 4 hours. It's a very, very good freedom. If the patient have something and you are having something, you're working here and there like that. So it gives you very good malleability, and you can change the dosing, change the protocols as you like, according to how much volume you have, according to how much stuff you have, like that. So it's very important like this. And also all the data are almost reproducible in the same. Changing the protocols will not change much the imaging results. So it's very good for the day-to-day work. And for the panel C, we have a stress image, and also you make a stress for the patient, give him the dose, make a stress image after 15 minutes, wait for 4 hours, give the patient a dose, make a resting image. For this one also, okay, we have another 1/4 protocol, which is a very important in the last few years. We gave, for that one, we can make a stress only image for the technetium, because if we make only a stress image for the technetium and it was normal, we don't need to proceed for the other images. Why we proceed for the rest? Yani if you have a defect in the stress image for this technetium, why we go for the resting image? Because we need to know if this stress, this is a defect in the stress image is not only an artifact, it's a true defect from ischemia. So we'll take another. Hello. معلش يا جماعه المايك لو سمحتوا، بس المايك اقفلوا المايك لو سمحتوا. تمام. But now, so you want to make sure that then you are taking the resting image. But for the stress, if from the start, if you take the stress image and this stress image was normal already, no need actually to go for the resting image. So it's called, this protocol is called protocol. This is also one of the important advantages in the technetium. This will enhance the process of diagnosis of the patient. Right. Here is the treatment protocols. We will not go through this one, but for the pharmacological stress, we have three important materials. We have adenosine, dipridamole, and dobutamine. And also, you know exactly that in the adenosine and dipridamole, ولاد عم. Because usually the dipridamole act through generating adenosine inside the body. And the dobutamine is also working in another area. Right. For the adenosine, this is a natural endogenous molecule normally produced in myocardial vascular smooth muscle and endothelium. It's also present. لو سمحتوا بس لو حد فتح المايك، معلش يا دكاترة، لو حد فتح المايك يقفله. سامعيني لو سمحتوا؟ تمام. Thank you. Right. It is shortly present in the extracellular space with extremely short half-life. Usually adenosine half-life is less than 10 seconds, and it binds to the thromboxane A2 membrane cell adenosine receptors, producing direct arterial vasodilator. So it's a very important direct vasodilator. This is the adenosine. In normal coronary arteries, there is an increase in the myocardial blood flow by one injection, single injection of adenosine, by approximately up to 5-fold. It's 4.5-fold compared to the baseline. It's very important. This increase, usually if we use the adenosine, it's a very reproducible data. It means that you will have a 4.4 difference in the image between the resting image and the adenosine image. It's very important to make you to have a very reproducible data for the patient presence or absence of ischemia. During the stenotic patient, in the stenotic patient, creating a flow differential flow and inhomogeneous distribution of perfusion tracers. This is very important because usually the adenosine, is going to work in the normal myocardial, in the normal coronary artery, and it is not going to work very well if in a stenotic, significantly a stenotic coronary artery. And this will create a differential or inhomogeneous distribution of the blood flow. And also according to that, there will be an inhomogeneous distribution of the tracer. The tracer, usually we use the technetium in most of the time now. This is very important, and this is the basis of how we can calculate or how we can elucidate the presence of myocardial ischemia. However, depending on the severity of the coronary stenosis and coronary flow reserve limitations, true ischemia can occur because of a coronary steal phenomenon. This is very important drawback because it is a very important, very, very effective vasodilator. Sometimes during the injection, the patient himself will suffer ischemia. Sometimes he will suffer ischemia, and you should be careful and ready to manage these cases. So, principally in collateral flow dependent arteries. The adenosine and the dipridamole are also indicated in the patients with left bundle branch block, paced ventricular rhythm patients on pacemaker, patients with very recent acute myocardial infarction, less than 3 days, and you want to detect the rest of the myocardium, to detect if the patient was managed non-invasively, and then you want to have a risk stratification for patient to send him for a place with an invasive facility, then you can use the adenosine as an exercise tracer for this exercise, pharmacological exercise for that patient, and also recent angioplasty in the patients with recent angioplasty and starting and having another new type, a new chest pain very early after angioplasty, after PCI. Right. The adenosine should be administered. This is very technical, yani. Adenosine should be administered through an intravenous line. So it is infusion with a dual port Y connector using an infusion pump at a rate of 140 milligram per kg per minute. It's microgram per kg per minute over 4, 5, or 6 minutes. So this continuous infusion is very important. So why it is Y connector? Because sometimes if you have any complication, you can give injection immediately if the patient has myocardial ischemia, if the patient has bronchial problems like that, whatever. Yeah. The mild increase in heart rate and modest decrease in the blood pressure results from adenosine infusion. So the immediate results, usually you will have some increase in the heart rate and you will have some decrease in the blood pressure. The injection of the tracer through the Y connector should be performed after 2 minutes, okay, from the start of the adenosine, within 4 to 5 minutes of infusion protocol, or after 3 minutes with 5 or 6 minute infusion protocol of the beginning of the infusion, which should be continued for another 3 minutes. That means that after, if you are going to inject the patient with the adenosine for 5 minutes, on the second minute, you should, after the second minute of the infusion, you should give the radio tracer through the Y port, the IV line with a Y connector port. And you should continue after the tracer injection, you should continue the adenosine for another 3 minutes. Right. If you have already, you will give the adenosine for 6 minutes, then you will give the injection after the tracer injection after 3 minutes, and you will continue after 3 minutes. This is very technical. This is for the people who work. Right. What about the dipyridamole? Usually it produces coronary vasodilatation through increasing adenosine, natural adenosine tissue levels, by preventing its intracellular reuptake and deamination. So now the dipyridamole is the precursor of increasing the adenosine. So here it has the same effect like we have already talked about adenosine. The increment in coronary flow produced by dipyridamole does not differ significantly from that produced by adenosine. Coronary hyperemia induced with dipyridamole is somewhat less predictable and lasts longer because the dipyridamole has longer half-life than adenosine injection. So because of that, it can reproduce continuous effect of increasing adenosine level and increasing coronary vasodilatation. So it is more half-life, it's more than 15 minutes than that induced by adenosine. So in dipyridamole, if you start if your patient will start to have an ischemia, chest pain like that, you will be expecting that this might last longer because the adenosine half-life is very small, but here the dipyridamole injected already is longer half-life. It will stay for 15 minutes, and this will make continuous increase of adenosine inside the coronary artery, and in vasodilatation increase. So that the induced induced by adenosine, due to the longer half-life, it's around 30 minutes of the dipyridamole. Right. Dipyridamole is administered manually as a continuous infusion at a rate of 0.56 milligram per kg intravenously over 4 minutes. This is a single dose. You can just wait the patient, calculate the dose, give it slowly intravenous over 4 minutes. This results in modest increase in heart rate, modest decrease in the blood pressure, same as adenosine. The tracer is injected 3 to 4 minutes after the completion of dipyridamole infusion. Why? Because it is the half-life of the dipyridamole is around 30 minutes. Right. Supplementation of dipyridamole infusion with low-level exercise for 4 to 6 minutes soon after the end of dipyridamole infusion. Injecting the tracer during the performance of exercise reduces the side effects of the vasodilator and improve image quality. What does that mean? In some hospitals, in some centers, after they giving the injection of the dipyridamole, then they can exercise the patient on very low level exercise for 4 to 6 minutes, either through a bicycle or through a treadmill. Sometimes even they can put for him a bicycle, just small bicycle, very small mild level of exercise for 4 to 6 minutes, like the 6-minute walking distance. And this will increase immediately. This will enhance the tracer uptake because it will enhance the effect of dipyridamole and also will combat the decrease of the blood pressure. Sometimes the patients, as we have, they notice decrease in the blood pressure, but with exercise you will combat the decrease in the blood pressure. Right. What about the dobutamine? For the dobutamine, here the effect is completely different. Dobutamine is an adrenergic receptor antagonist, and that means that it usually increases oxygen, increases the chronotropic effect, increase inotropic effect, and that will increase myocardial oxygen demands. So dobutamine is an adrenergic agonist with a positive inotropic and chronotropic effect, which increase myocardial oxygen demand, secondary to dose-related increase in myocardial contractility. Every one of us know this one more than me. High doses of dobutamine result in a secondary increase in myocardial blood flow only with the normal vascular beds. So dobutamine is able to increase the myocardial blood flow for the coronary only if the patient has a normal coronary vascular bed. And how much it's like that? Only 3-fold. This is compared to that of the adenosine, which is reached up to 4.5 folds, with the potential to provoke ischemia in vascular beds supplied by significantly stenosed arteries. Right. Dobutamine stress testing is indicated in patients who cannot undergo exercise. All of us know very well how dobutamine can be like that. Dr. Mona, if you are following with us, how much time we have now? I'm sorry, wallahi.
لا هو هيك الزوم فتح لنا يا دكتور احمد.
طيب
الزوم فتح لنا الميتنج.
طب ليه بس كده الناس كده هتزهق مننا. اوكي.
هو بس كان عايز اسال هل تفضل انهي فيهم؟ يا هيك بالخبره كده
لا ادينوزين طبعا.
لا بالنسبه للثاليوم نعم.
في التريسر التكنيشيوم هو دلوقتي الموست امبورتنت في التكنيشيوم. And we have already, this is a very good question. And also يعني for the lack of redistribution, there was a drawback that it is not very good in detecting of myocardial viability. But actually we have too many protocols to also detect myocardial viability. One of these protocols, it was done here in the National Heart Institute. الحقيقه كان لينا سبق في الكلام ده. كان الله يمسيه بالخير حد من الناس القدام، الدكتور الصبان كان بدأ معانا. كان كانوا we were injecting the patient or giving the patient اللي هو الميتابوليك ايجنت اللي هو ترايميتازيدين، اللي هو ناسي اسمه في الترايميتازيدين. كان عباره عن mitochondrial enhancer، وده كان very important to make an improved uptake of the technetium by the mitochondria of the muscle cell, and usually it gives us a very good result to detect myocardial viability. So الحقيقه يعني for the radio tracer we prefer technetium. For the pharmacological stress we prefer the adenosine. This is very important. Right. We can continue. For the dobutamine stress testing is indicated in patients who cannot undergo exercise stress and have contraindications to pharmacologic vasodilator stress, because usually what I did not mention that dipyridamole sometimes can can make a bronchospasm complications. And the patients, if they have atopy or asthma or like that, they can the apretamol can increase their asthma or their problems. And also adenosine can make significant decrease in blood pressures. So these are very important drawbacks. So it has not been studied as extensively as adenosine or dipyridamole in the evaluation of and prognostication in patients with chronic disease. This is the dobutamine. Right. The infusion pump starting at 5 milligram per kg per minute, maybe microgram per kg per minute, 10, 15, 20, 30, up to 40 microgram per kg per minute. This is very important. Every 3 to 5 minutes. Exactly, you are using as an exercise treadmill test. So like the Bruce protocol, you are going every 3 minutes, you are increased from low dose to high dose. So you are with an increment of 5 microgram per minute. So it's 5, 10, 15, 20, after that 30, and then 40, every 3 to 5 minutes. The tracer should be injected when the maximal predicted target heart rate, the patient, when he achieves more than 85% of the maximal predicted target heart rate, or at 1 minute into the dose of 40 microgram per kg per minute. So at the dose of 40 microgram per kg per minute, if the patient did not reach the target heart rate, then you can inject your dose. And sometimes we can give an enhancement for that one by the atropine administration, because atropine will block the parasympathetic stimulation effect on the heart rate, and this will increase the heart rate more and enhance the dobutamine effect on the myocardium. So atropine administration from 0.25 to 1 milligram intravenous may be required to increase the heart rate response to more than 120 beats per minute with the maximum dose of dobutamine. And severe side effects may require intravenous administration of a short-acting beta blocker like the esmolol. So it should be ready inside if you have a problem with the dobutamine or side effects. Now look at this. This is the principle of the camera. Usually, if the patient is settled like that, we have two cameras, two sides cameras. Like see it from B. B is much more obvious than what is there in A. So you have the two cameras here, and these two cameras are focused immediately on the heart with 90 degree between them. So it is like perpendicular to each other. And usually both of them then starts to rotate around the heart up to 180 degrees. So through that one, we can obtain from each camera, we can obtain 2D images, and these 2D images are then digitalized in the computer software to be reconstructed into a 3D images. In some cameras also, we have the capability of doing a CT immediately. We have a CT head, because this CT sometimes can also give us a very good for the attenuation, very good information about the calcium scoring for the patient, and this will enhance the images, and also it can give us a very good idea about the reasons of attenuation or reasons of defects for the myocardium. For the images, sometimes we have too many attenuations, or we have faults in the image, and this is why we have that. Sometimes we have also a built-in CT head inside with the camera. This is another type of camera. Usually it is, as you see, it's also two heads perpendicular to each other connected to the patient, and the patient is almost semi-sitting. It's like a U shape. This is also very important to enhance the timing of the images, to enhance the timing of the examination. Instead, sometimes the patient stays in the very old cameras. He should stay very stable in his position with no single movement for 30 minutes. But with dual heads, now it was decreased into maybe 20 minutes or 15 minutes. With these types of cameras, then it can decrease even to 5 minutes or 7 minutes, like that. So it's very important. All these are multiple detectors that used like this. This one for the patients who cannot sleep, because sometimes if the patient with a severe heart failure, he might have an orthopnea. So this is very suitable for these patients. The patient is almost sitting and taking his image. This one is also with 3 heads, and all of them are focused on the heart itself with a 180 degrees. Now they are already 120 degrees, so the degree of rotation is very minimal, and the image is very, very rapid, taking the image and finishing the examination for the patient. All these are types of cameras produced through the wall. Then what about the image acquisition? Usually each head, from these cameras, you will find that there is a series of 2D planar images. Usually each camera will take a photon that it is emitted already from the body, from the tracer, and then it is reflected through an image, or color-coded image. This will produce 2D image. From each camera, it is a planar image, like just an analog image. But this analog image, after that, it will be reconstructed into a digital image. So, and then this digital image, it will be already again reconstructed with the images from the other camera or the other 2 cameras to reconstruct a 3-dimensional images. So this is the steps of the images. So we have a series of 2D planar images acquired by gamma camera, and signal from photomultiplier tubes are digitized, because actually, as you see in the picture, this is the myocardium. It emits the gamma rays, and these gamma rays are captured by the photomultiplier units. This camera is consistent of multiple photomultiplier units of sodium. I'm not sure the sodium crystals. I'm not sure I don't remember the component of the crystals. Anyway, these images are taken like that. These photomultipliers usually have a minimum X-ray sensitivity and maximum X-ray sensitivity. In between, it can be activated and create an image. But if the tracer of in the myocardium has a gamma rays that it is less than the minimum, the photomultiplier tube will not be sensitized or not be activated. And if it is much more higher, also it will not be activated. So it should be within a certain range. Right. For the image acquisition, series of 2D images, then reconstructed into 3D images, data set using back projection mathematics. This is mathematical, this is computer software. It was the one who is calculating all these images. Right. This is very important. This view is very important. This is how is the camera is dividing the heart planes. So we have 3 planes. We have a transverse, this is transaxial or short axis. We have long axis, and the long axis, it has 2 axes. One, it is vertical long axis, and the other is horizontal long axis. So if you have here, these are the 3 important standard planes that the image is created upon, because in this, that means that we will have 3 sets or 3 row data for the myocardium. We will have short axis images, we will have vertical long axis images, and we will have the 3rd group. It will be a vertical long axis images, vertical and horizontal long axis images. Here are another digitation for the image. If you have on the left side, you will have the right ventricle and the left ventricle. This is the short axis. So all the data set, all the images will be like that. All of them with the left ventricle, the right ventricle will appear or will not appear. Okay, but on the right side, you will have the vertical long axis. The vertical long axis for you will see a horizontal heart. So this is a very important point. In the vertical long axis, you will see a horizontal heart with the inferior wall, apex, and anterior wall. Right. If we have a horizontal long axis, now we will see for the horizontal long axis, you will see a vertical heart. The apex is above in the top, the base in the down, and the left side with the left lateral wall, the free wall in the on the right hand, on your right hand, and the septum in your left hand towards the right ventricle. So this is very important. The short axis is very important. خلاص, يعني it's very clear. We have the I'm not sure if I can. No, I cannot. الحقيقة, because I'm using my tablet, I cannot use a pointer. So for the left side image, short axis images, in the top you will have the anterior wall, you will have the lateral wall on the left side on your right hand, okay, and in the septum you will have the septum and the inferior wall. That's fine. But for the vertical long axis, you will have the apex, you will have the anterior wall, you will have the inferior wall. For the horizontal long axis, you will have the apex, lateral wall or anterolateral wall, and the septal wall. This is how to do. This is a very important also. I think this one is very clear how to take a short axis image. So the short axis image, you will have the left ventricle exactly like a circle with a dot inside. This dot, it represents the cavity, the left ventricular cavity. And this small purple crescent is the right ventricle. And the septum is here is present in red and yellow, and the all other myocardium, the lateral, anterior, and inferior wall. This image is very clear for all of us. Yeah, it doesn't need too much to. What are the myocardial segments? We usually divide the myocardial segments by one of two methods. Either we use a 20 segment method, or usually we use a 17 segment method. Okay, and for the 20 segment methods, anyway, for either method, usually you use anterior, anteroseptal, infroseptal, inferior, infrolateral, anterolateral, anteroapical, and infroapical. And all of these images, and then accordingly, they are collected to give data about left anterior descending distribution, left circumflex distribution, and right coronary artery distribution. So that means that when we have a defect taking some certain walls, like wall number 1, which is the anterior, plus infroseptal, plus anteroseptal, so 1, 2, 3, and 4, then I'm expecting that I have a defect or I have a stenosis left anterior descending. If there is like that, if we have segments number 9, 8, 9, 10, 7, like that, then we will have LCX like that. So this one, it will be much more clear like that. Here is a very important bullseye. This is the polar plots or the bullseye image. This is also very, very important in the analysis. As you see, segment number, look at the diagram. Inside the diagram, in the middle, there is segment number 17. This is the apex. And after that, you will have 4 segments, 13, 14, 15, 16. 13 is the apical anterior wall. 14 is apical septal wall. And 15 is apical inferior wall. And 16 is apical lateral wall. So now these are the 3 apical walls. And then go outside. 7, 8, 9, 10, 11, 12. These are the middle of the heart, the mid segments. So 7 is mid anterior. 10 is mid inferior. Here we have 12 and 11. 11 and 12 are the lateral wall, but we have anterolateral wall and infrolateral wall. Anterolateral wall is segment number 12. Infrolateral wall is segment number 11. For 8 and 9, we have septal wall. This septal wall is divided into anteroseptal wall, and number 9 is infroseptal wall. Okay, right. If we have the same, and also this is also going out after that to 1, 2, 3, 4, 5, 6 segments, which are at the base. So number 1 is we have basal anterior. Number 2, we have basal anteroseptal. Number 5 is basal infrolateral. Okay, fine. If we have a 20 segment, what will be the difference between this bullseye with 17 segment, as you see, and the 12 segment? The 20 segment digitization or 20 segments protocol, you will have a divided horizontal line at number 17. At the apex, you will have anterior apex above and inferior apex down. And in segments number 14 and 16, you will be also further divide the septum, which is 14, into anteroseptal apical and infroseptal apical. And for number 16, you will have also anterolateral apical and infralateral apical. So by the 20 protocol segments, you will have 3 more segments mainly related to the apex. The apex itself and the apical lateral wall is subdivided, and the apical septal wall is subdivided. Otherwise, all the segments are the same. Now, this is how we can depict or we can read the image, because the heart, the ventricle here is represented on the left side by a cone, very long cone, as you see, with the apex down, the base up, and now there is a very important myocardial perfusion defect in the inferior segment. So this is apical inferior and apical mid. So it is apical, mid, and inferior. And basal inferior wall defect. Actually, yeah, this black color is a defect. And here, if it is like that, so that means that the defect is taking the whole myocardium from the base to the apex. So we have apical inferior, we have mid inferior, and we have basal inferior defect. This is very important. If this cone is on the other side above, so now it will be anterior like that. So this image is very important also. Here are also again the polar maps. This diagram is very important in calculating the diagram, in knowing the types of nomenclature of the segments of the myocardium. Like number 1, we have basal anterior wall. Number 2, we have basal anteroseptal wall, and like that until we have reached number 17 is the apex. Also in the metal tomograms, you will have what you will see in the image of the patient. So you will have the short axis. These are the segments of the short axis. Then you will have the horizontal heart, which is the vertical long axis. And then you will have the horizontal heart, the vertical heart, which represents the horizontal long axis, which all the segments. But look now here again on the polar map. In the polar map, you will have 3 different colors. Maybe the white color, and on the right side is the light gray, and on the the anterior and left side is the dark gray. The white represents the right coronary artery. So the segment number 4, number 3 and 4, 9 and 10 and 15 represent usually the right coronary artery redistribution. Distribution. Segments number 1, 7, 13, 17, 14, 8, and 2, all of them are left anterior descending distribution. Segments number 16, 12, 11, 12, and 5, 6 represent left circumflex redistribution. This is very important summary for how to interpret the image of the result of the patient. What about the scoring system? We have score from 0 to 4. If you have an image and you want to interpret the image, the imaging defect, you mean you have a perfusion defect, you will image. So if the patient has normal perfusion, this will take a score of 0. But if the patient has mild reduction in the image quality, this will take a score of 1. So number 1, it will be mild reduction in the count, not definitely abnormal. So sometimes we cannot say it is true abnormal. But if you have 2, number 2, score number 2, it means that there is a definitely abnormal image, and that means that there is a moderate reduction in the count. And number 3, then you will have severe reduction in the count. And number 4 is absent uptake. Absent uptake usually means non-viable myocardium. Right. What is the sum stress score? The sum stress score, we are making a scoring system for the patients. So when we can, through that scoring system, this one can give us a very good idea about the risk stratification of that patient. So if from these scoring systems, from that one, when you collect them and this sum stress score, it will be less than 4, then the patient is almost normal. And that means that the percentage of the cardiac death in the rest in the coming 10 years, it will be only 0.3. And the risk of myocardial infarction, it will be only 0.5. But if the patient has mild abnormal defects from counting from 4 to 8, then the risk of MI, it will be 2.7, and the risk of the cardiac death, it will be 0.8. And then for 9 to 13, moderately abnormal, so you have a moderate defect, then the risk will be increasing. Like MI will be, risk of MI in the future MI is 2.9, and the cardiac death is 2.3. And if it is more than 13, the MI risk will reach up to 4.2%, and the cardiac death risk, it will be rising to 2.9%. This is also the same like that, so we can go for this one. What about now the protocols of the imaging, like the gated SPECT? What is the gated SPECT? The gated SPECT is, now we are in the, slide 41 actually. والله أنا تعبت. دكتورة منى، يعني please يا جماعة, do you like to take another appointment؟ احنا في رمضان ولا ايه رأيكم؟
مع حضرتك ممكن الجمعة الجاية؟
ممكن نكمل من الاول كده بقى الجمعه الجايه ان شاء الله لو تحبوا، لان احنا كده 40 سلايد وسنه 40 زيهم، فيعني كده احنا
خلاص الجمعه الجايه ان شاء الله.
اهو الكاونتنج قدامكم خلاص، فاذا حبيتوا يا ريت ان شاء الله. طيب
بس
هنبتدي المره الجايه من
بدري شويه يا دكتور احمد.
حاضر ان شاء الله، ممكن المره الجايه على الساعه 1 لو عايزين، مفيش مشكله.
خلاص ان شاء الله باذن الله، يبقى ميعادنا الجمعه الجايه الساعه 1
باذن الله ان شاء الله.
ان شاء الله باذن الله. شكرا يا دكتور احمد، ومستنيين في انتظار الاسئله اللي على المحاضره دي
باذن الله يا جماعه، باذن الله
ان شاء الله. شكرا يا دكتور احمد.
شكرا.
السلام
عليكم.
مع السلامه.